Curious about how benzodiazepines work? Join us as we break down their science and clinical uses. So we're going to start a series on benzodiazepines. We're going to discuss benzodiazepine kinetics, dynamics. We're going to talk about benzodiazepine withdrawal, and then we're also going to talk about benzodiazepine-induced neurological dysfunction. So firstly, let's look at the structure of benzodiazepines. The general structure of all benzodiazepines is they are a benzene ring fused to a 7-membered diazepine ring. So there's effectively 2 rings, and they all function as positive allosteric modulators of the GABA receptor. They require the presence of GABA to take effect. And that's an important distinction between benzodiazepines and barbiturates. Barbiturates are full agonists and do not require the presence of GABA. Therefore, they're able to activate the GABA receptor. Therefore, they're able to induce a neuroinhibition, and therefore they are much more lethal than benzodiazepines. Benzodiazepines, because they are only positive allosteric modulators, are less dangerous than barbiturates. Now, we need to think about GABA in the context of glutamate. So glutamate is the primary excitatory neurotransmitter, and GABA is the primary inhibitory neurotransmitter. There's a chain of metabolic reactions that converts glutamine, an amino acid, to glutamate, and then glutamate to GABA. So they're all basically the same structure with minor alterations. And GABA, an inhibitory neurotransmitter, is derived from glutamate, an excitatory neurotransmitter, by the action of an enzyme, glutamic acid decarboxylase. Now, if we look more closely at the GABA-A receptor, we can see that it has a central chloride channel and 5 pentamers, 5 parts which kind of relate to each other to form a straw-like structure that penetrates cell membranes. And so when the chloride channel is activated, chloride moves from the outside of the cell to the inside of the cell, therefore causing what we call hyperpolarization, which means that it requires much more energy for that cell to be activated, therefore it's relatively inhibited. And there are different binding sites for the benzodiazepines and for GABA and for barbiturates on this pentameric 5-part straw that surrounds this chloride channel. Interestingly, benzodiazepines bind at the interface of what we call the gamma-2 and the alpha subunit. So I told you that the benzodiazepine receptor had 5 parts to it. Some of the parts are named alpha, some of the parts are named gamma, and the benzodiazepine site is at the interface between the gamma-2 and the alpha subunit. And benzodiazepines have roughly similar affinities for GABA-A subtype receptors that contain alpha groups labeled 1, 2, 3, and 5. Now, this is very geeky, but it's important to understand that there are GABA-A receptors with alpha-4 and alpha-6 subtypes, which are insensitive to benzodiazepines, but are sensitive to neurosteroids, and so they're called the neurosteroid-sensitive GABA-A receptors. If you can't get your head around this, just remember this one fact, that not all GABA-A receptors are activated by benzodiazepines. So there are some receptors that do not respond to benzodiazepines. Now let's look at the functional effect of benzodiazepines. So I've said they increase the frequency of chloride channel opening in the presence of GABA. They allow ingress of chloride, therefore causing what we've already said, this hyperpolarization of the neuron. Now the difference, or one of the other differences between benzodiazepines and barbiturates, is that barbiturates increase the duration of chloride channel opening. Benzodiazepines increase the frequency of chloride channel opening. Barbiturates increase the duration of chloride channel opening. And then secondly, they do not require the presence of GABA, and hence barbiturates in overdose are lethal. Now, we need to understand that all benzodiazepines that function as benzodiazepines by interacting at the GABA-A receptor, so it's receptor subtypes 1, 2, 3, and 5, they all do the same thing, but there are many types of benzodiazepines. So what is the difference? And I think the key differences to understand are one, their relative potency, and two, their half-lives. So if we're thinking about relative potency, it's very common to actually compare all other benzodiazepines with 5 milligrams of diazepam. And so it's important to understand that potency gives you an indication of dose, and the half-life gives you an indication for its clinical indication, what condition we would use it for. So if we look at alprazolam, the equivalent to 5 milligrams of diazepam would be 0.5 to 1 milligrams. And so therefore that's got a relative potency of up to 10 times that of diazepam. And the half-life of alprazolam is 6 to 25 hours. So it's a fairly short-acting benzodiazepine, and that would be used for conditions like insomnia or acute anxiety. If we move on to Oxazepam, 15 milligrams to 30 milligrams of Oxazepam is equivalent to 5 milligrams of diazepam, so it's potentially 6 times less potent than diazepam. And it's got a half-life of 4 to 15 hours. So again, very short half-life. It's used for insomnia, and it's also used, as we'll find out, for the management of withdrawal syndromes in situations where people are at risk of benzodiazepine accumulation, either due to age or liver failure. Then we've got Clonazepam, and it's very potent. It's got a potency of 0.25 to 0.5 milligrams relative to 5 milligrams of diazepam. So it's up to 20 times more potent than diazepam. It's got quite a long half-life, 22 to 54 hours, and so it would be used for long-term anxiety conditions or, for that matter, withdrawal from alcohol. Then we have nitrazepam. It is equipotent to diazepam in that 5 milligrams of nitrazepam is equivalent to 5 milligrams of diazepam, and it's got quite a long half-life as well, 16 to 48 hours. So again, it would be indicated for anxiety. Lorazepam, it has a potency of 0.5 to 1 milligrams relative to diazepam 5 milligrams. So it's up to 10 times more potent than diazepam, very similar to alprazolam. But it's got a shorter half-life than alprazolam. Its half-life is 12 to 16. So again, it can be used for acute agitation, acute anxiety, insomnia, and it can also be used to treat withdrawal, especially in liver failure. Then we have Temazepam, the standard drug that is used for insomnia. It's got a potency of 10 to 20 milligrams of Temazepam relative to 5 milligrams of diazepam. So it's potentially 4 times less potent than diazepam, but it has a short half-life as well, between 5 and 15 hours, which makes it very suitable for the management of insomnia. Because again, in insomnia, you need to fall asleep, but you need to wake up the next morning as well. And then we have the Z drugs, Zolpidem. Zolpidem has a potency of 10 milligrams to 5 milligrams of diazepam, and it's got a very short half-life, 1.4 to 4.5 hours, so it's very good at getting people to sleep, but not necessarily keeping them asleep. And then Zopiclone, it's got a potency of 7.5 milligrams to 5 milligrams of diazepam, so just slightly more potent, and its half-life is 5 hours. Again, just enough to get someone to sleep, but perhaps not to keep them asleep. So there we have it. We've got the potencies and the half-lives. And just to summarize, the most potent benzodiazepine is Clonazepam, which is 20 times more potent than 5 milligrams of diazepam, followed by Alprazolam and Lorazepam, which are about 10 times more potent. And in terms of half-life, the longest acting would be Clonazepam with a half-life of 54 hours. And the shortest half-life would be either Oxazepam or Temazepam. The Oxazepam's half-life is 4 to 15 hours. Temazepam's half-life is 5 to 15 hours. Now, let's go back to thinking about benzodiazepines and their clinical effects in terms of lethality. Now, I've said before that barbiturates are much more lethal than benzodiazepines because benzodiazepines are positive allosteric modulators. And in fact, the lethal dose, the LD50 of benzodiazepines, has not yet been worked out. Documented benzodiazepine-associated deaths have involved short-acting, high-potency benzodiazepines such as alprazolam or triazolam. And the deaths are more likely with co-ingestion. So particularly with opioids, the co-ingestion of opioids with benzodiazepines can increase the risk of death by a factor of 10. And really, we need to understand that 30% of fatal opioid overdoses in the United States have involved benzodiazepines, but that's usually with co-ingestion. So we'll continue our talk on benzodiazepine kinetics in the next episode, but for now, that's all for today, folks. My name is Dr. Fergal Armstrong, and this has been Cracking Addiction.